Hello, everybody, and welcome to another session of dental shadowing. Today we have pediatric dentist Dr. Virden here with us today, and she's going to give us a shadowing session all about pediatric dentistry and her journey into dentistry. So thank you so much, Doctor. When you're ready, you can go ahead and take it away.
Okay, thank you so much for having me. I'm very excited to be here with you all talking tonight about pediatric dentistry and going through a few cases with you. So we'll go ahead and just get started. So for a little introduction, I'm Jordan. I'm a pediatric dentist and I work outside of Baltimore, Maryland. So I'm here on the East Coast. In terms of my education, I've kind of kept it on the East Coast. I went to college at Virginia Tech, and then I did both my dental degree and my pediatric residency training at the University of Maryland School of Dentistry. Currently, I work as an associate pediatric dentist at a practice called Smiles for Children. I'm also a, Dean's faculty or part-time faculty at Maryland. So it's been nice to work with the residents on, 1 or 2 days a month. And then just some hobbies. I enjoy spending time, with family and friends, traveling and being outside and hiking. So just kind of basic things, but that's a little introduction about me. So in terms of my journey into dentistry and you all thinking about what your journey into dentistry and pediatric dentistry or whatever specialty or general dentistry is going to be like, I'll just share a little bit of how kind of I got to where I am today. So I kind of always knew growing up that I wanted to work with children. I used to teach swim lessons to little kids, babysit, did all of that. So I always knew I wanted to work with children. And then during college, I spent time going to the free clinics down in Southwest Virginia and saw the real need for dentistry and the impact that dentistry can have, not only on the teeth, but also on your whole body in terms of heart health and, leading to progressive disease. So really was interested in dentistry at that point. I applied while I was in college and I did not get in the first time. I was very devastated, very upset, but ultimately, I think honestly, it was probably the best thing that ever happened to me in terms of becoming a dentist was that I didn't get in the first time. That allowed me to have a gap year where I worked as a pediatric dental assistant, and I really began to love pediatric dentistry and thought that that would be what I would want to do when I, got through with dentistry and wanted to specialize. Once I was in dental school, I was pretty certain. And some of you may be certain now of what you might want to do. Some of you might not know if you want to specialize or not, but I tried to tailor my experiences towards pediatric dentistry because I knew ultimately that's what I wanted to do. So during college, it's important to be involved in things, and I don't think they necessarily need to all revolve around dentistry, of course. If you have a passion or you have something that you love doing, I think that also helps you to be a really well-rounded applicant as well. Some of the dental students in my class, for example, were artists and did, painting, or some of them made jewelry. One of my dental student colleagues was a cardiac researcher before he came to dental school, and another dental student played minor league baseball. So, these are all interests in all things and parts that make you a well-rounded applicant. So some of the things that I participated in were Mission of Mercy, which is dental related. Those are the free dental clinics where they offer 1 or 2 days of dental services for those that can't afford dental care. So that's a really rewarding experience if you all ever have a chance to get involved with those. I was obviously in the pre-dental club. I did health education and awareness team. This is basically where we just taught like sun safety, contraceptive safety, and nutritional and diet classes to fellow students on campus. I was involved in Greek life and I did Relay for Life. So, most of those are health related, but by no means does it all have to be dentistry related or does it all have to be health related. In college, I shadowed mainly general dentists, and this was good because I got to see a wide variety of procedures on a wide range of patients. And then, of course, like I said, during my gap year, I was a pediatric dental assistant. In terms of advice for college or while you're in college, first and foremost, and this is especially true once you all are in dental school, as well as to always take care of yourself. You can't pour from an empty cup, and while you may be trying to make the perfect application or doing the best that you can in school, you want to remember to always take care of yourself first and foremost. Obviously, you want to be involved in extracurricular activities and volunteering to have a well-rounded application, but also to explore your passions and what you're interested in outside of dentistry. Always say this: don't compete. Oh, don't compete. Don't compete. Collaborate. I know there's a lot of memes out there in dental school about gunners and things like that. And those things do exist, but I feel like we all get farther together than we do separately. So whenever you can, kind of collaborate with each other so everybody can succeed. Seek out shadowing opportunities just like you guys are tonight. So that's awesome. On your dream of being a dentist, if a test or a class isn't going well. I didn't get in the first time. I had some classes that I really struggled with in college, and I had classes that I struggled with in dental school. But if you keep trying and doing your best and, trying to achieve your dream and doing what you can to get there, I think it will work out. It certainly worked out for me. And I would say I wasn't a, straight A student at the top of my class, but I just tried to work as hard as I could to achieve and be where I wanted to be. In terms of dentistry, so during my first application cycle, I would say I kind of just tried to apply everywhere. I wasn't really strategic about finding schools that would fit me the best. And I really didn't study for the DAT as well as I should have. I don't know why I didn't take it that seriously, but I didn't, and I don't recommend that at all. I only did the Kaplan course, and I wasn't really engaged in the process. So like I said, I did not get in the first time, and I can think back as to why there were reasons that I did not. However, on my second application cycle, I tried to be much, much more strategic. And because I didn't attain my goal, I was that much more hungry to try to get it and get into dental school. So in terms of DAT studying, I did the boot camp. I did Chad's videos. I don't know if those still exist anymore, but they were super, super helpful. DAT Destroyer, and then I would try to do problems consistently, whether they were the DAT or the PAT, even if it was just like 1 or 2 a day for 5 to 10 minutes, just so I was constantly always reviewing it. And then for dental schools, I tried to look at what each school had to offer. If they offered shadowing days or like open houses, I would try to go and see if I could see myself there. Geography, where did I want to practice in the future? Cost, which I know sometimes is unavoidable. Dental school cost goes up every year. But I tried to be diligent about going to a school that wasn't super, super expensive. How I felt about the school after interviewing, if I got interviews, could I see myself there? And just all around thinking about, how I envisioned myself as a dental student and what schools best matched up to that. Ultimately, I chose Maryland Dental School, and then we'll go through a few pros and cons of that dental school on the next slide. So I would say there's a lot of good about Maryland School of Dentistry. Just like, again, you'll see memes about all different kinds of dental schools and all different kinds of dental student experiences. And I think you have to take them with a grain of salt because ultimately, we're there to learn and become dentists. And of course, there's frustrating times, but there's also really, really good things about each school. So for some of my good things about Maryland, it's the first dental school in the world. We have like a little sign outside of the dental school. So that I thought was kind of cool. The school does do a lot of world-renowned research in pain, facial pain, microbiology, and a lot of your professors that you have are really world experts, like very respected experts. We have a diverse patient population because we are located in Baltimore City, which is awesome. So you get to see a lot of different patients, a lot of different things. So it makes for a really good cases and really interesting people that you get to talk to, which I love. Good class size. We have over 100 dental students per class. However, I find that, our class, at least when I went there, and it seems like the classes below me are all pretty friendly to each other and try to help each other out, which is nice. We have a lot of opportunities for volunteering and giving back, which I loved. I thought that was really great. Solid foundation with sim labs. I felt like I had a good foundation with the hand skills before I went into clinic, which is important, and not getting too nervous the first time you're with an actual patient. We also have a clinic, special care and geriatrics. So you'll rotate through and you'll get to work with patients with special healthcare needs, as well as our elderly population. And I thought that was something that was really interesting. And I hadn't heard about that before at other dental schools, so I like that. Your third and fourth year of dental school, there's a lot of clerkship opportunities where you can receive more clinic time in certain specialties like oral surgery, pediatric dentistry. There's like an implant clerkship. So I think that's really nice to give students who are thinking about specializing that time to really explore those specialties. And I feel like we had a lot of caring faculty that really cared about you, not only as a student, but also as a person. The bad tuition, of course, is expensive. It's not the most expensive dental school out there, but it's still expensive. Sometimes, depending on your like what group you're in for your clinic, it can be challenging to complete requirements just based on what types of procedures that you need versus you have the patients with those experiences that you need. So that can be challenging, but I feel like that's at every dental school. Patients no-show sometimes. I think we had like a 30% no-show rate. So that can make things challenging, especially nowadays with COVID. And sometimes you need to be a self-starter and advocate for yourself to have your requirements and needs met. But again, I don't think that's unusual. Hello? Hey.
It's okay. I think we lost you there. You can go ahead and reshare your screen.
Okay, sorry about that. I'm not sure what
Okay.
happened. Did it stop on the good versus bad slide about Maryland?
Yeah.
Okay, I'll pick it up from there. Sorry about that.
No, it's totally fine.
Alrighty, I'm gonna go ahead and bring that back up. Can you see it now?
Yeah, we can see it.
Okay, perfect. Alrighty, we'll just continue on there. Sorry for that little hiccup. So transition from dental school to what is pediatric dentistry. Pediatric dentistry is a interesting specialty because it's age defined. So typically we'll see children from, honestly, I've seen children from a few days old all the way up to 24, but we also see a lot of patients with special healthcare needs. So we'll see those patients. We have some patients in our practice that are in their 30s, but they have, overall pretty healthy dentition. They don't need to go to any other specialist. So we still see them, which I thought is one of the best things about pediatric dentistry is we see a lot of patients with special healthcare needs. During residency, which is typically a 2-year residency, I think there's only a couple of programs that are 3 years. We receive extra training in child development, behavior management, special healthcare needs, and we also treat patients during residency or trained to treat patients with oral sedation, IV sedation, and in a hospital setting with general anesthesia. So like I said, I did my dental school training at Maryland, and then I liked it so much I stayed for 2 years to do my residency training. This is just a picture of my co-residents, as well as some fun pictures of our residency program. I still keep in touch with my co-residents and love the program there. So really a wonderful time. But it's a little bit about University of Maryland's pediatric dental residency is that it's a hybrid program, meaning that we have some classroom time, we have some clinic time, and we have some hospital time where we see cases in the OR. And we also take on-call patients or emergency patients. We see them in the emergency room. We got special training, just like the previous slide, on child development and behavior. The good thing about Maryland is they help prepare you for your written and oral boards. So to be a pediatric dentist, you don't need to be board certified. You just need to have your certificate training, but many pediatric dentists will go on to become board certified by taking the part 1, which is the written, and then You drive down to North Carolina this year and you would do an oral, I think it's either 2 or something hour long oral examination. So that's what I'm preparing for now, which is a little nerve wracking, but that's okay. We see patients under general anesthesia in the hospital setting. We did a lot of sedation cases, which is great because now that I'm out in private practice, I feel more comfortable doing those oral sedation cases. And of course, we have the on-call experience where we would see children with trauma. You know, I saw kids who were in car crashes, kids who got bit by dogs, as well as like facial swelling and cavities and things like that. So you see a lot of different things and a lot of different experiences, which was really, really great. And now I'm in private practice. And so this is the dental assistants, doctors, and everyone at last year's 2019's Christmas party or holiday party that we had. So this is the group that I work for now, and I love it. It's an awesome place to work, honestly. So my work week is 4 days a week. So I'm off on Wednesdays and I work every other Saturday. We do take calls, so we do see emergency patients. And it's not too bad. It's not as intense as in residency. So it's 1 week every 7 weeks, which is not bad at all. Our day starts around 7:45 and goes until 5 p.m. We typically do fillings and things like that from 8 to 1, just because we find that children are a little bit more fresher in the morning, a little bit, more able to tolerate those types of procedures. Whereas exams and cleanings and that kind of stuff we do all day long from 8 to 5. And then if we're going to have an oral sedation case, that would be only at 9 a.m. every day of the week. Sometimes we have them, sometimes we don't. And then in addition to that, on your off day, so mine would be if I'm off on Wednesdays, my Wednesdays, that's the day that you would see patients in the OR or the hospital setting. So overall, it's pretty busy. It was slowed down a little bit because of COVID and parents being, anxious and nervous, understandably, to have their children come to the dentist. But now it's picking up again as people are starting to get more comfortable, which has been very nice. So in terms of the kinds of procedures that a pediatric dentist typically will do, we do fillings, just, regular fillings, tooth-colored fillings. We really don't do any silver or amalgam fillings. We do sealants, stainless steel crowns, which are the silver crowns, and some dentists will do white crowns, which look basically like adult crowns. They're the aesthetic white crowns. We do tooth extractions for both primary teeth and some adult teeth if needed on a limited basis. We look at oral pathology. We can do excisions and send that for a biopsy. And we do lip and tongue tie releases. In terms of braces, some pediatric dentists are trained in like the clear braces, the Invisalign. But at our practice, we mainly stick to things like space maintainers. So basically, if a child loses a tooth early and we want to preserve the space, we'll put in a space maintainer. And so we would make that. And then, of course, they also do pharmacologic behavior management, oral, IV, and general anesthesia. So important terms in pediatric dentistry, and I could go through like actual terms that we use, but I think the more important thing for pediatric dentists and pediatric dentistry is how to talk to kids and how to communicate complex things in kid-friendly language that makes children comfortable and helps them to understand what's going on in a non-threatening, non-scary, and understandable way. So these are some of the kid-friendly dental terms that we use on a daily basis. And it's also really important to think about each child's age and kind of you don't want to talk down to like a 14-year-old. I'm not going to say I'm going to use the sleepy juice. Maybe for a child that's younger, for a teenager patient, if they want to know, maybe I would talk to them about what it is. But for your younger patients, 4, 5, 6, maybe, these are really helpful terms to help them to understand what's going on. So I think that's one of the important aspects of pediatric dentistry is not only the technical dentistry, but also the behavior management and understanding child development and appropriate terminology and talking to children and getting them through procedures successfully. So I think that's one of the most important, honestly, the most important things that we do as pediatric dentists. Some things that we use, of course, are dental x-rays. If we have a tooth with a large cavity or a cavity that's causing pain, we do some pulp testing. So we'll palpate, so we'll feel along the gum line, we'll feel along the tooth, and then we'll percuss the tooth, meaning we'll tap on the tooth with our mirror to see if it causes pain, to see is the nerve alive or is it dead or is it really inflamed. So that's some of the pulp testing that we would do as a pediatric dentist. And then, of course, we get patient history from parents and patients. So now I'm going to share some cases with you all, but before I do that, I'm just going to share a little bit about the teeth. And you guys have probably seen this before, so it'll just probably be a little review. So this is just a very quick review of dental anatomy. So obviously you have the crown, you have the root of a tooth, and then you going from outside to in, you have enamel, then dentin, then the pulp, and then the cementum is what's kind of overlying the root of the tooth. And then, of course, the pulp is where the nerves and the blood supply is located. All right, and then tooth types. We have our incisors, our canines, our premolars, and our molars. Children's teeth, baby teeth, they only have incisors, canines. There are no premolars in the baby tooth dentition. So that's something kind of, I don't know, kind of interesting to note, I feel like. And so this has a little bit about the description and the functions of each type of tooth, because each type of tooth performs a specific function. So then we have our primary versus our permanent teeth. And you can see in this picture, for the primary teeth, we only have our incisors, our canines, and our molars. Typically, the primary teeth start to come in around 6 months of age. And then we start to lose and get new teeth around 6 years old. Some children will get teeth before 6 months, some children after 6 months, but generally around 6 months of age is when the teeth start to come in. And then you can see the adult teeth. We have our incisors, our canines, our premolars, and our molars. And so we have 20 baby teeth, and we can have up to 32 adult teeth, if you count the wisdom teeth. And so this is just a quick introduction to dental pathology, just because that's kind of an area that I find very interesting. So we can have extra teeth. So if you look at the number 1 figure, that's a supernumerary tooth, or what's called hyperdontia. And those where that arrow is pointed, if we have extra teeth or supernumerary teeth in the front of the mouth, those are called mesiodens. So those are some mesiodens right there, those extra teeth in the front of the mouth. By your 2 top front teeth. If we're missing teeth, or we have less than the normal number of teeth, we have hypodontia. So that would be figure number 2. We're missing some teeth there. The image 3 is a larger than normal tooth size, so that's macrodontia. And you can see that on the front tooth, the maxillary front tooth there. And then having a smaller tooth, or a tooth that's smaller than normal size, is microdontia. So that image number 4 shows a picture of what's called a peg lateral. That's that tooth that's little in size and it's kind of peg shaped, so we call them a peg lateral. And that's just a kind of a brief intro to some dental pathology there. And then we have Xray types. Excuse me. So image number 1 is bite wings. So that's a picture of a right-sided bite wing. And that's used to look at cavities, or look for cavities, look at bone height, and look for calculus, which is basically hard plaque. You can see the crowns of the teeth, as well as the molars, premolars, and typically you would want to see part of the canine as well, but this is probably part 1 of a 2-part shot of the right side of the mouth. Periapical x-rays show the crown of the tooth and their roots of between 1 to 3 teeth. So that's image number 2. You can see the crown, and you can see all the way down to the root, the ends of the root, so the root apex there. Number 3 is a maxillary or mandibular occlusal, and this is a picture. Number 3 is a maxillary occlusal, and it shows the anterior teeth and roots. And we use maxillary occlusals pretty much all the time when it comes to trauma or looking at cavities or anything in primary teeth. And then the last image, image number 4, is a Panorex. And this is typically a growth and development type of x-ray to look at how teeth are forming and where teeth are forming. But it's also used to look at the jawbone, sinuses, nose, mandible and maxilla. And it can also be used in cases of trauma where we feel like we may have a jaw fracture or, a condyle fracture or something like that. So we may use it for trauma, but mainly it's used for growth and development. Okay, so now we're going to get into our first case. And then I have questions kind of attached to each of these cases. If you want to answer them, you can, or if you want to just think about the answers, you can. Either one is fine with me. So this is our first patient. They're a 7-year-old male, and they arrived to the dental clinic with the chief complaint: there's something bothering my tongue behind my front teeth. And then you always want to review the patient's medical history. It's not significant. They're a healthy child with no allergies, and they're not taking any medications. So I want you all to think of, some questions that you might ask the patient to get more information about what is going on behind their front teeth that their tongue is feeling. Alrighty. So this is what you see, but some questions that you might want to ask the patient or the parent is, how long have you noticed this? Has it caused pain? Does anything make it feel worse or better? Is it currently bothering you? Things like that, just to kind of get a visual in your head before you take a look clinically. So you look, you do an extraoral exam, meaning you look at the face, the cheeks, the neck, you look at the lymph nodes along the neck and under the mandible, and you don't see any significant findings there. There's no swelling or anything like that. Then you look at the intraoral exam. So now you're looking inside the mouth, and you see the patient is in mixed dentition, meaning they have some baby teeth or primary teeth and some adult teeth. You don't really see any cavities. You see maybe a little bit of staining on those molars, but you don't see anything significant in terms of cavitations or anything like that. Teeth and gums on the mandibular or lower arch look normal, but when you look at the maxillary or upper arch, you see that there is something there behind the front teeth, and it looks kind of like it's made out of tooth structure. It's also very pointy. So at this time, you would probably want to take an X-ray. And so you decide to take a periapical X-ray where you can see the crown and you can see the roots of the teeth, and you see, and you can think about what you're seeing on the X-ray, if there's something extra there. So this right here is an image of your two front teeth, and then there's a Mesiodens or supernumerary tooth in between those two front teeth. So in thinking about what the treatment for this may be, there's a couple factors and things that you want to think about. In this case, that extra tooth ended up being extracted. I mean, it was removed, and so you can see the extraction site image directly after. You can see the extra tooth, the Mesiodens, on the little gauze, and then you can see the post-op X-ray where you no longer see the extra tooth there, and you don't see any broken roots or anything like that. So that's one treatment option for Mesiodens, is to remove them. And so here are some pictures of other Mesiodens, because they can look, different presentations depending on each child can look a little bit different. So you can take a look at those clinical pictures and X-rays. So Mesiodens are supernumerary or extra teeth located in the anterior, and 82% of them are located in the upper arch in the anterior, meaning the front of the mouth, and 25% of these extra teeth come into the mouth spontaneously. And then the most common shape for Mesiodens is conical or peg shape. So that kind of skinny, circular, conical shape is how most of them present. And the majority of ones that I've seen in clinic are that conical shape. I actually had a patient today who has two supernumerary teeth. And so we're trying to figure out right now if we're going to take them out early or if we're going to wait for them to see if they'll come in on their own. So you do end up seeing it more than I would have thought that you do in clinic. So why do we care about Mesiodens and kind of where they are and what's happening to them? So Mesiodens can cause some problems. So having extra teeth by the normal permanent teeth can cause issues. So it can cause the permanent teeth to not be able to come in correctly. It can cause crowding. It can cause impaction. So the permanent tooth or the tooth that's supposed to come in can't come in at all because the Mesiodens is blocking the position. It can cause cyst formation, and they can resorb or wear away the roots of the surrounding teeth. So this is why we want to take X-rays and films on a regular basis, like a Panorex, that growth and development picture, or periapical, to see the crowns and the roots of the teeth to check for these Mesiodens and make sure that we don't have any extra teeth where we don't want them. In terms of the treatment of Mesiodens, we can either extract them or we can monitor and leave them alone and just, monitor them very carefully. So the reasons we would want to remove a Mesiodens would be if it's preventing eruption of an adult tooth, if it's displacing other teeth, if we see a cyst or some sort of pathology, or if it's resorbing the roots in the surrounding area, or if it's bothering the patient. If it comes in and it's bothering their tongue and it's painful, or something that's bothering them, can address it at that time. We want to consider monitoring Mesiodens or the extra teeth if there's no pathology present, if the adult teeth came in successfully and without issue, if they haven't damaged the surrounding teeth or the surrounding teeth roots, or if they're just unerupted and they're not causing any symptoms. So it's a little bit of an either or. It depends case by case whether you're going to take out these extra teeth or if you're going to leave them and monitor them. And then when in doubt, you can always have a patient evaluated by an oral surgeon or an oral pathologist just to get another set of eyes or a second opinion about what you should do. So that was case one. Now we're moving on. We're switching gears a little bit to case two. So this is a patient that you will meet on the after hours emergency line. And this happens very, very frequently. Mom calls and she's upset. Her child fell and they knocked the tooth out, but the mom can't find the tooth anywhere. It's nowhere to be seen. It's not on the floor. They think maybe, the child swallowed it. And so the information that you get from the parent is that you have a 15-month-old male who was playing on a rocking horse and fell. The parent, once the child got up, noticed that there was bleeding from the upper lips and the top arch. There was no loss of consciousness, no vision changes, and no nausea. And the patient is a healthy child. So think about what kinds of questions you would want to ask mom to get more information about this emergency call that you got. So you have the patient come in, and then in terms of questions, and we'll go through this kind of towards the end of the case, that you would want to ask is, how long ago did the accident happen? You always want to ask, and I know it was addressed in the previous slide, about any loss of consciousness, nausea, vision changes, because you're always checking for any concussion protocols as well, any head injury in addition to dental injury, because that would take precedence over the dental injury. You want to know kind of where the trauma happened. Can you find the missing tooth? What does it look like? I always have parents send a picture, and I feel like that really helps as well, just because then I have an idea of, as I'm driving over to the office, of kind of what I'm going to be dealing with. So those are just some things to think about. So this is when the patient comes in and you've taken a look. This is what you see. So you see an upper lip laceration, you see a missing front tooth, number E, so that's the baby tooth, the very front tooth, baby tooth, on the right side, and the gum tissue looks red and swollen and bleeding. The other maxillary teeth in the area are slightly loose, but they're not, going to fall out, they're just a little bit loose. And so this is what you see. So what would you want to do next, or what would you consider to do next? I always try to, if I can, take an X-ray, just because sometimes it may look like the tooth is missing, but it's actually there. So you take this would be a max occlusal. You take a max occlusal, and this is what you see. So you see that the tooth actually is not missing. It wasn't knocked out. It's actually been knocked up into the bone, and possibly it's interfering or it's close to that developing adult tooth. So this is something that we see pretty typically with kids who are running with toys and fall, or are, running on the ground and fall, or falling up the stairs. This is something that we would see with those types of falls and those types of injuries. So what do? You discuss with mom. Of course, you always want to tell the parent what's going on and what you see clinically and on the x-ray. So you let her know that the primary tooth number E has been intruded. And I guess I'll back up here. Primary teeth or baby teeth are numbered A through T, with A to J on the top arch and K to T on the bottom arch. I should have said that a while ago, but this is the two front teeth up top are E and F. So tooth number E has been intruded. You recommend monitoring the tooth to see if it will come back in. And then you go over signs and symptoms of infection to monitor for. And this includes things like an abscess, draining, spontaneous pain, pain waking the patient up at night. So you go through all of that with mom. And then you recommend the patient to follow up at 1 week, 6 months, and 1 year. You'd also probably have another follow-up at like 6 to 8 weeks. And then you discuss possible damage to the adult tooth. So a lot of times when we have any type of injury to a baby tooth where it's knocked out of position, or it's knocked up and it's been intruded, you always want to talk about potential damage to the adult tooth, because at the time of injury, when the baby falls or the toddler falls, wherever that tooth root of the baby tooth goes, it can knock into the adult tooth within the jaw and cause problems or cause a little defect on the crown of that adult tooth. So I always make sure that when I'm going over any type of trauma that involves a baby tooth, that I tell the parent that there may be some damage to the adult tooth as well, just to inform them so that they're not surprised if later on the adult tooth does have a little, like a little mark or a little discoloration. So this is what I was kind of talking about before, how we work our patients up who have trauma. You always want to use a structured approach. Sometimes it can be very stressful when you have a parent and a patient who are upset, or they're in pain, or the parent's very worried. So you always want to follow through the same type of structure for each patient so that you don't miss anything. So of course you want to go over your medical and dental history, always looking for any medical conditions, medications, or allergies, because you want to make sure first and foremost they don't have any severe medical condition that you need to be aware of before addressing the trauma, like a bleeding disorder or a heart condition that needs pre-medication or something like that to, that you need to figure out before you go ahead and treat the trauma. Medications, just to always be aware of, and allergies, especially medication allergies, because, if you're going to prescribe an antibiotic, you don't want a patient to prescribe antibiotic that a patient may be allergic to, or another medication that may either interfere with your medication or the patient has an allergy to. So always very important to go over that. Social history, including caregivers. Pediatric dentists are mandated reporters for child abuse and neglect. So that always is a factor in trauma, is to also evaluate for any potential child abuse and neglect. Trauma history, you want to know who, what, when, where, any medications given, signs of concussion. If you feel like there is a signs of concussion, either the patient lost consciousness, they're nauseous, they're not oriented to person, place, and time, then you would send them for evaluation for the concussion prior to helping them dentally. Once you have the patient in your office, you want to go over a soft tissue exam, looking at the lips, the oral mucosa, the gums, any frenums, which are the muscular attachments of our lips and our tongues. Then you want to look at a hard tissue exam for fractures, discoloration, pulp testing like we talked about. And you want to look at both unaffected and affected teeth and kind of compare and see how they may look different. You also want to look at the outside of the face, the ears, the cheeks, the nose, and the neck, just to make sure that you're not missing anything. Again, x-rays can be helpful to kind of give you a full picture. We usually take, max occlusals or PAs. For fractures and injuries with gravel, glass, or where you think the patient fractured a tooth and it could be in the lip, you take a soft tissue x-ray so you can kind of see where all of those things are, either if they're in the upper lip or the lower lip, and you can retrieve them. And then once you have all of your data, you can start to make a diagnosis. So you kind of want to go through the structured approach each time so that you don't miss important pieces of information. And then just a little more deep dive into intrusive loxation. So this is just kind of a little cartoon of an intrusion where the tooth did not hit the permanent tooth bud. So that's just a little cartoon for you to look at. They consider hitting the permanent tooth bud or not hitting the permanent tooth bud. So that's just an image there for you. So the tooth may be almost or completely disappeared, which is why some parents will call and say that they think that the tooth has been knocked out is because it's all the way up in that bone. So on the x-ray, you can look at the picture and see if the tooth is displaced toward the bone plate, meaning more towards the lip, or towards the permanent tooth. And depending on how the tooth looks, if it looks longer or shorter, that's how you will be able to tell. I can tell you in real life that it's not always as clear cut as this, because you can have other movements of that tooth too that make it a little bit more difficult to kind of tell where that tooth is in space. So that's why, regardless of how it looks on the x-ray, I always let parents know that there could be damage to the permanent tooth. And then in terms of treatment for primary teeth with intrusion, we typically will monitor and see if the tooth is able to come in on its own. And so here you can see how we have an intruded tooth at 2 months after injury, 3 months it's coming in, and then 1 year, it's pretty much back to its normal position. And you can see the x-rays that go along with that. So we allow the tooth to reposition itself because any damage to the permanent tooth happened at the time of impact. The fact that the tooth is still intruded, it's not continuing to cause problems to that adult tooth. Whatever problems it caused happened as soon as that child's tooth hit the floor or hit their toy or whatever it was that they, fell with. Eruption can take a long time for the teeth to come back into the mouth. It can take up to 6 months to 1 year. I have a patient right now who fell in November and intruded her front tooth, and now it's just starting to come back in. So, it's been a while since November, so we're kind of waiting and seeing if she'll be more in 6 months that'll come in, but I have a feeling it might take up to a year for her for that tooth to come in more. Recommendations to parents: can give over-the-counter Tylenol or Motrin. Be careful with eating because when that tooth starts to come in, it may be more likely to be painful or maybe a little bit loose. Keep the area clean. Brushing and flossing is super important. And then reevaluation, keeping an eye on that tooth. 1 week, 6 to 8 weeks, 6 months, and a year. Typically, we'll take x-rays of this tooth probably yearly if it comes back in. If it doesn't come back in, it may take more x-rays than that. So favorable outcomes, if the tooth we think is going to be okay, you obviously have the tooth re-erupt, which is great. If you see that, you see continued development of the adult tooth, and you have pulpal healing. You don't have random pain, you don't have swelling or abscess. Unfavorable outcomes, meaning the tooth is probably going to maybe have to come out early or be extracted, would be if we see any signs of infection, or if it's negatively impacting the permanent tooth, meaning we don't see any continued root development, or other problems like a swelling or a fistula. And then if we see that, then we take out the baby tooth, and we're quick to do that. If there's a negative complication, we'll take it out. So that's kind of one of the many traumas that children can have. Kids, I feel like, are very accident prone, but I feel like intrusion is one that we see a fair amount of for the baby teeth. And then this is the same patient that came in, and this is their follow-up a year later. So you can see the tooth came back in. and it's not bothering them. The tooth color looks good, looks similar to the surrounding teeth, which is great. And then this X-ray is kind of cut off, but the adult teeth have continued to form a little bit more. So we have a favorable outcome here, and likely we'll just continue to monitor this tooth. All right, and then our final case. And this is a 2-year-old, 7-month, 2-year, 7-month-old for their new patient exam. So you'll notice for all of these cases, I'll give you the age in year and month, or just in month. And we do this a lot in pediatric dentistry because depending on the child's age in year and month, their development and their ability to cooperate may be different. So for example, a 3-year, 2-month-old, their ability to cooperate and get through procedures is going to be very different than a 3-year, 9-month-old. So that's why for all of these cases, you'll see the age in year and month. But anyways, so the mom's here, she has a chief complaint that their front teeth have cavities, and the patient's a well child, no allergies, regular pediatrician visits, no medications, no medical problems whatsoever. Mom tells you that the child is not in pain at this time. You perform a knee-to-knee exam and the patient's uncooperative. They're moving their hands around, they're crying and they're screaming. So that's typically how for this age group these exams go. And I'll show you a picture of a knee-to-knee exam on the next slide. But I want you to think about what are some questions that you can ask to find out more about the patient's diet, home care, etc. Alrighty. And then now that you've thought of maybe a couple, we'll move on. So for the patient exam, you'll see that little navy picture is the knee-to-knee exam positioning for the exam and cleaning. And this is typically how we do most of our exams for children 3 years and under. They sit with their parent and they'll lay back on a pillow into my lap. And then I'm able to get a good look, and they're able to hopefully be comforted by their parent or caregiver who brings them. So the picture on the bottom is what you see when you look at the child's mouth. So you see some cavities on those front teeth, and it looks like they have severe early childhood caries on the maxillary front teeth. You don't see any swelling, any signs of an abscess, no mobility, and the child is not seen in pain when you're looking at the teeth and touching the teeth. You ask about their nighttime routine, their brushing routine, if they have any habits. And so from those questions, you learn the child has a bottle of milk nightly right before bedtime to help them fall asleep. The parents are only brushing the teeth in the morning, and the patient eats a variety of food and has apple juice throughout the day. So mom is interested in learning more about preventing decay. What can you tell her? What are some things that you think maybe she should know, or maybe that might help her to help her child prevent from getting more cavities, or to not get more cavities? So some of the things that I talk about is that the last thing to touch a baby's teeth or a toddler's teeth before they go to bed should be the toothbrush and the toothpaste. If they're going to do milk at nighttime, it needs to be before the brushing. We also talk a lot about putting water in the bottle instead of milk, or watering down until it's completely water the milk. We talk about 2 times a day brushing with a smear size of toothpaste, and then keeping things like juice or candies to mealtime and trying to only keep it to 1 meal a day. So those are some things that mom maybe can try out at home. And then mom wants to do something today to help stop the cavities from growing while the patient is uncooperative. And the child right now is too uncooperative for a regular filling or a stainless steel crown or something like that. So what is something you can suggest? So I want you to think about that, and then we'll go to the next slide and see what we ended up doing. Okay, so this is the treatment that we did, and we'll talk a little bit about it a little bit further down. So our recommendations for home care, what mom's going to try to do at home, would include brushing the teeth in the morning and night with a smear size of fluoride toothpaste, limiting juice throughout the day to meal times only. So this is kind of like what we talked about. No milk after the teeth are brushed. We want the last thing to touch the teeth to be the toothbrush and toothpaste, and coming to see us more frequently. So having the child come to see us every 3 months, just so we can actively watch and monitor those cavities to make sure that they're not getting bigger. And you may be wondering why the child's teeth now are black. That is actually an application of what's called silver diamine fluoride. And we use this a lot in kids that are uncooperative or pre-cooperative, so little kids that have cavities that we're not able to do traditional fillings in at that time. So SDF, or silver diamine fluoride, is made up of metal ions and fluoride. And as you can see, the cavities that are treated with the SDF turn black, and sticky cavitated enamel gets hard, which is what we want, because that means kind of like the cavity's frozen and it's not going to get bigger at that time, as long as the parents are doing what they're supposed to at home as well. So sometimes this can take up to like 2 or 3 applications, and you may need maintenance applications, but it goes on clear. You just kind of paint it on clear, and then over time takes, I would say maybe sometimes you can see it happening in minutes, but sometimes it takes over the course of like a day or so. That area will turn black wherever there is decay. As you can see, there's some SDF on the gums that goes away over like a week. But where it's on the tooth structure, where it's on the cavities, that's permanent. So the teeth are permanently staying that color from the silver diamine fluoride. Eventually, we can put fillings over these to try to mask that color. But for children who are pre-cooperative, who have large cavities, this is a very good treatment option for them. So this is just a little bit more information about silver diamine fluoride, and you can see the same pictures here. So when you go to put it on, you want to try to keep it on the tooth, keep rubbing it around the tooth for about a minute. We usually see patients a month afterwards and may do another round of the application, and the enamel will become dark and hard, which is how you know you've had a successful SDF application. We can put it on the front teeth or the back teeth. The anterior teeth or the front teeth have a little bit higher success rate. Originally, silver diamine fluoride was for like hypersensitive teeth, but then they found that it also worked to stop cavity progression. So it works in 2 ways. So the fluoride ions, obviously, just like our fluoride in our toothpaste or fluoride varnish, works on tooth structure to help with the remineralization. And silver ions are heavy metal and they're antimicrobial. So it's kind of a best of both worlds material or medicament. And then for case selection, we can't use it on everything. So if we have a tooth that the cavity is so large it's into the nerve of the tooth, we can't use it. If we have a patient who's had a history of spontaneous or random pain or pain waking them up at night, we can't use it. If we have small to, I would say, moderate sized cavities that we can get to with the silver diamine fluoride, then we can use it there. But large cavities and cavities into the nerve of the tooth, we can't. So our American Academy of Pediatric Dentistry does support us using 38% silver diamine fluoride as part of a comprehensive caries management plan. So what that means is it's not, it may be something to help us stop cavities from growing to a point that the child is cooperative enough that we can do a filling or we can do a crown. So for this child, for example, we may keep the silver diamine fluoride on there for a year or 2 and then replace it with a traditional tooth colored filling. This is kind of like a big or a hot topic in pediatric dentistry right now, whether we do this as a final filling or if this is just a step in getting the patient ready to have some other type of treatment like a typical filling. So this is kind of a hot button issue within pediatric dentistry, but I will say we do use it fairly often for patients. Most of the time, if we have cavities in the front teeth, parents may not like the silver diamine fluoride. We have a lot more patient and parent acceptance for using it on the posterior teeth or the teeth in the back. So those are my cases. They're samples of cases that I see a lot in pediatric dentistry, a lot in our clinic. So we'll wrap it up here with advice to future dentists, and then just if you want to get in touch with me, how to do that. So advice to future dentists, We always want to treat the person first, not the teeth. So I know we talked a lot about, this patient with their silver diamond fluoride, but we always want to remember that, little Timmy or little Johnny is a person first, and to look at them as a person and not just, their teeth, and think about treating the whole person. Always want to try to do the right thing. This is important in dental school. It's important in real life. Whenever you can do the right thing, sometimes it's not always easy, but you always want to try to do your best to do the right thing for your patients and for yourself. You get out what you put in. So the more you give into learning something new, procedure, patient experience, the more you get out. And this is especially true for dental school. The more that you're involved in your patient's care and learning, the more I feel like you'll get engaged in the process, and the more that your patients will see you're engaged in the process, and ultimately the more you'll learn. Again, collaboration over competition. And then you can't pour from an empty cup. Take care of yourself. That's like a really common theme. It's easy to get overrun in dental school, but it's so important to take care of yourself. And then also to believe in yourself, because you have to be, the first and foremost person believing yourself and hyping yourself up. So that is all that I have for you all tonight. Really happy that I got to talk with you all. So is it okay to stop broadcasting, or do you want me to turn my video on? Is that okay, or leave it how it is now?
It's totally fine. If you want to just answer the questions like this, and we can leave it on the
sure.
screen.
Yeah, that's fine. Yep.
Okay, cool. So our first question in the chat was, what's the greatest challenge you think pediatric dentistry poses compared to general dentistry?
I think that's a good question. I think honestly, it's finding a way to treat children of all ages and all cooperation levels in a way that is good for them dental treatment wise, but also behavior management wise. I think oftentimes we'll get referrals from general dentists from patients who may be difficult or challenging, and then it's up to us to figure out the best way to treat that child to help them get through dental treatment successfully. And so whether that's, using a little nitrous oxide or happy air or oral sedation or general anesthesia or nothing at all, I think that's kind of the most challenging part, is how do we treat each patient as a unique individual and make sure that they're getting not only the treatment that's right for them, but also kind of personalized behavior management to them.
And then another question here in the chat was, how do you handle parents who are skeptical and ask a lot of questions about radiographs and nitrous oxide?
Sure. I honestly don't mind those types of parents. I try to figure out more than, kind of get annoyed by them or try to push them off. Try to figure out why it is that they have, why they have the questions, and then what it is that they have heard about the topic. A lot of times, I think when you approach parents that way, it gives you an opportunity to educate them. And I've had a lot more success with going about it that way. Like, well, why do you feel this way? I respect that you feel this way. Tell me what you've heard, and trying to educate from there rather than saying, we need to take these x-rays. I can't believe you're not allowing x-rays or what have you. I think, trying to show empathy and understanding their point of view goes a long way. But it can be frustrating at times, but I think just trying to see where the gaps in knowledge are and answer those gaps, I think, is helpful.
And then someone asked, what motivates a pediatric dentist to seek board certification if it's not necessary to practice as a general dentist?
I think honestly I don't know, I can't answer for everybody, but I think at least for me personally, that is like the highest level that you can achieve as a pediatric dentist. So to me, it's more of like a personal professional goal, is I want to be at the highest level of my training that I can. And so to do that is to become board certified. And I would say, I think, at least the co-residents that I had feel the same way, that that's the highest level of your training. And so if you can attain the highest level of your training, that would be, why they would want to attain board certification. I also think that it does help you with getting your hospital credentialing. It may help with that. I'm not exactly sure, because I know now I'm filling out a lot of credentialing forms, and they have a section to make sure that you are board certified in whatever your specialty is. But more important than that, it's to practice at the highest part of your specialty, at least I think.
And then another question here was, what do you do when you get stressed at the job?
So children are very, very good at like sensing your mood and sensing the feel and the vibe. They can read you very easily. So what I try to do is if there's a stressful situation, I try to remind myself that, I'm in control of my feelings, and my feelings can help a patient be successful or unsuccessful during treatment. So I try to stay calm and just try to work through it as best as I can, because I know if I'm stressed out or if I seem like I'm trying to rush through a difficult part, or if I'm, trying to not really think about, how stressful the situation is, or getting myself worked up, then the child's going to feed off of that energy, and it's going to kind of snowball. So I think trying to, and this is same for adult patients too, if you're getting stressed out, to kind of figure out how you can calm yourself down and try to work through it logically, because if you're stressed out in a stressful situation, you can't really think that well. Kind of everything gets jumbled together. So whether that's like taking a few deep breaths, or thinking, about what's going well, or telling yourself, you are the dentist, you're kind of in control of the situation, and you have to get yourself, the patient, everything through the procedure in a professional and in a successful manner. I think that's important to do for both pediatric patients and adult patients. I don't think getting stressed out really helps too much. And it took me a long time to learn that. But I think you have to be in control of your emotions to know that you know what you're doing. And you know that you need to stay calm and not let things kind of get out of hand, because your patient's going to feed off of that same energy.
And then I know you talked about all the different factors that played into you choosing a dental school, but if you had to choose the most important factor that played into you choosing your dental school, what would it be?
I would say probably for me choosing Maryland was, honestly, location was a very big factor. And their like sim component and their technology component I really thought was very interesting. And a lot of the faculty that I talked to that day were just really, really nice, and the dental students were really nice, and they kind of made me feel at home. So I didn't really know I was going to go there. I wanted to go there, but the interview kind of really solidified everything for me, because it just seemed like a really like cohesive union. Everybody seemed to kind of get along pretty well and liked each other, and generally seemed to like being there. So that I really thought was great. And location, I knew I wanted to practice in Maryland. I knew I wanted to stay in Maryland. So I was really hoping to go to school in Maryland and continue my journey there. So location and kind of just the feeling I got at the interview day felt like it was the right fit for me.
And then our final question for you is, what is your favorite procedure to perform?
Let me think. That's a good question. I would say I like to do stainless steel crowns, and I like to do front teeth. The front teeth on like not little kids, but on like teenagers who have like fractures and things like that. I do feel bad for them, or like aesthetic builds up, just because it's kind of like a little bit of artistry in dentistry. So you can do, you can make them look pretty, you can make them look nice and smooth them, and it's just a nice procedure. And then the stainless steel crowns I like doing, because there's a lot of like fun behavior management you can do about that, like picking out a princess crown or a superhero tooth and talking kids through it that way. I just think it's kind of fun. But those are my two favorite ones, but there's nothing that I really hate doing on a daily basis. I kind of like everything, but if I had to pick, those would probably be my two favorite.
Awesome. And Dr. Virden, go ahead and stay behind, but that is going to conclude our session today. Thank you so much for talking to us. We really enjoyed all the fun cases and learning a lot of terminology about pediatric dentistry.
Thank you for having me.
Guys, the post-session quiz is linked in the chat, and it will also be in our Instagram bio. So thank you guys.